Hey class, it's Dr. Dorf here as we start to move into some of the more advanced concepts throughout the class and the semester. Wanted to spend some time doing a lecture covering asthma. So want to kind of talk about the definition of asthma, then we'll kind of get into patho a little bit, and we'll talk about diagnosis and triggers, which is really key. Talk about the different classifications of asthma. We'll talk about treatment and the stepwise approach that's associated with treating asthma, and then kind of wrap up with when to refer. So asthma has a very long, complex, wordy, and quite frankly, boring definition, but the official definition of asthma is a common chronic disorder of the airwaves that is complex and characterized by bronchial hyperresponsiveness, the tendency of airways to narrow excessively in response to a variety of stimuli that provoke little or no bronchoconstriction in persons without airway disease. After reading all that, I think I'm going to have an asthma attack. Basically, what does that mean to you? What do you need to know? So asthma causes inflammation within the smooth muscle of the airways. Or the inflammation causes the smooth muscle in the airways to constrict. So within the smooth muscle, you also have lumen openings. We're talking like your alveoli and whatnot. Think of those openings as being the end of a water hose. You put a kink in that hose while it's running. What happens? No water is going to come out the end of it, right? So that's basically what happens with asthma. Inflammation builds up. Smooth muscle constricts. The lumen within there causes it to constrict. Think of a water hose getting a kink off the end of it. No water is going to come out the end of it. Therefore, no air is going to come out of the small airways. So, one thing to consider, kind of going back to diagnostics over the summer, you guys should have covered PFTs, pulmonary function tests, and looked at those. And we're not going to rehash a lot of that right now, but you can look back on that on your own. But if you kind of remember what PFTs do, is that's a flow volume loop, is what that records. It records exhalation and then inhalation. And you're getting two things out of it. You're getting your FEV, or what's commonly referred to as FEV1. So FEV1, and that's going to be your forced expiratory volume. And that's basically the amount exhaled at the end of 1 second of forced expiration. You're also going to get in there your FVC, which is your forced vital capacity. Again, capacity, we're thinking of volumes. And what your PFTs give you, it's going to give you a ratio. As a matter of fact, you take your FEV, you divide it by your FVC, and you're going to get a ratio. Depending on different guidelines and literature, and also depending upon age, normal is typically going to be anything that is above 0.70 to 0.80. So while a lot of primary care clinics do have the ability to do pulmonary function testing within the clinic, a lot do not. But what they do have the ability to do is handheld peak flow meters, or handheld peak flow spirometry, which is one of the hallmarks, by the way, to being able to diagnose and treat asthma. A lot of patients have their own handheld peak flow meters. It's how they're able to measure when they're really getting into to trouble, the degree of inflammation. So what that's going to give you is something called your PEFR. And that's going to be your peak expiratory flow ratio. It kind of gives you a poor man's version of what you can get with the pulmonary function test, because you're going to be able to measure basically the peak expiratory flow, and this is based, and then you're going to have something that's called predicted volume. That predicted volume is based off of age, gender, and height. So it will give you a number of, this is predicted based off of those parameters, what that patient should be able to blow, which basically is kind of coming back to giving you a FVC. Then what they do blow through that peak flow meter is basically going to kind of stand for your FEV1. So you'll take what they blew on the peak flow meter, divide it by their predicted, and you're going to get a number that's going to be that or lower. So that's kind of how that works, and that should always be done. I do that with all my patients that come in that have asthma and COPD, because it's truly the only way that you know what stage they're at and whether you need to go up or down with your therapy and your treatment. So let's kind of talk about the pathophysiology now behind asthma. First off, asthma, key thing to remember when we're talking about patho with asthma is that it is reversible airway inflammation. As opposed to COPD, which is irreversible airway inflammation. So kind of what happens is, going back to when I was talking about the smooth muscle constriction and how the lumen constrict, this is all kind of due to inflammation. And I am a horrible drawer, so you're going to have to excuse my third grade drawing skills that I'm about to really rock here. But anyway, you have a couple of different nerve pathways and then receptors that sit on top of the smooth muscle cells. So if we were to consider this to be our muscle, we're going to have pathways coming down. Just like I said, can't even draw a straight line. And they're going to set up shop right there and there on either side of that smooth muscle. And over on this side, you're going to have beta, which is responsible for relaxation. And over on the other side, you're going to have M. That stands for muscarinic. Muscarinic receptors is what causes constriction. So our goal in asthma, if you were to look at this, what do you think we want to do? Well, we want to get as much air going through those small airways as we can, because we're dealing with constriction. So which one of these two do we want to stimulate more? We want to stimulate beta, right? So this is our goal in treatment, is we want to stimulate beta, and we want to block or inhibit these muscarinic receptors as much as we possibly can. So this also we'll talk about further. This is one reason why you have to be very careful if you have patients who are asthmatic and they also happen to be hypertensive or have heart disease. You need to find other alternatives besides beta blockers, because we don't want to block out beta. We want to stimulate that. But we'll talk more about that in a minute. So, and then also what's going on, and what we talked about, what's the hallmark of asthma, is what's kind of driving all this, is you have inflammation. That's driving the ship here. And of course, that's coming down and stimulating all of this. So that gives us three classes of medications that we use to help treat asthma. And I'm showing you this to understand that you understand what works from the pathology standpoint. So we're going to have, and these are medications that you're probably already familiar with, but we're going to have our anti-muscarinics, right? And then we're going to have in between there our anti-inflammatories, although we aren't talking about we aren't talking about NSAIDs, obviously. And then we're talking about our beta agonists. So if you were to look at this and you were to think which medication, which class are we going to use first? Well, again, we have inflammation that's driving all of this. So anti-inflammatories are going to be number one. And again, we aren't talking about NSAIDs. Instead, we're talking about what? We're talking about inhaled corticosteroids, right? So keep in mind it's corticosteroids. Sometimes it can be systemic. We'll write down ICS for inhaled corticosteroids. Again, not your traditional musculoskeletal NSAIDs. Our next one is going to be beta agonists. And then the anti-muscarinics are going to be third. You'll see that when we get into our stepwise approach of managing asthma. Also, what we have going on from a pathology standpoint with asthma is we have a whole lot of IgE that is being released. And if you kind of go back to your patho class, you know that IgG is one of the major components in terms of the histamine cascade, right? And so what happens when you have a lot of histamine that's released into the system, you're going to have a bunch of swelling, which is going to lead to inflammation, which is what we're trying to avoid, right? So within the histamine cascade, what do we have? What gets mobilized when IgE starts to really spike? You're going to see a whole lot of basophils and mast cells. So those mast cells, they release a lot of histamine. So what do we want to do then? Well, it's very important in the mainstay of asthma before we start getting off into our inhalers and so on and so forth. You want to make sure you're doing as much as you can in these patients to be able to minimize and block that histamine cascade. So we're able to do that how? This is fairly simple. This is kind of your treatment of allergic rhinitis or postnasal drainage. You're going to give antihistamines, and then you're also going to give your nasal corticosteroids, of which, most of those are now over the counter in terms of antihistamines. At least your first gen, second gen, about the only ones that are not over the counter, your leukotriene modifiers. They work on a specific arm of the histamine cascade. We'll talk more about that. in a minute. Most of your nasal corticosteroids are now over the counter. Flonase, which is originally the original molecule for the rest of these different inhaled corticosteroids, is over the counter. You still see it being marketed on TV in new various rapid acting ways and this, that, and the other, just trying to extend their patent. But you have generic Flonase, there's Nasacort, there's nasal Crom. So that's what we're really kind of focusing on. So you want to make sure that any of your patients that have asthma, that you're doing something to address this histamine cascade, and that you're making sure that you have one or both or multiple on board. So let's kind of talk about the diagnosis of asthma then. It's really based off of subjective history and of course your physical examination, but most of everything is going to focus around triggers, because something is triggering all of that IgE to be released and all of that histamine. So what are some of the most common triggers that we're going to see with asthma? Well, we just talked about one, and that's going to be basic allergic rhinitis or post-nasal drainage. You're going to find that in approximately 90% of patients with asthma, both adults and children. You're going to look for, and again, one of the reasons being is these are things that can get in and irritate the airways, right? So another thing that commonly, if you think about, again, the pathophysiology behind GERD, gastroesophageal reflux disease, what happens? You have a stimulation production of acid in the stomach. It comes up from the esophagus, and it can spill over, if left untreated, into where? It can spill over into the airway. So GERD is that's why GERD is one of the top 3 common causes of chronic cough. But it can also be adding fuel to the fire with asthma if you have uncontrolled GERD. So you need to assess for that. And then a predisposition or frequent, what patients would come in complaining of upper respiratory infections. They're coming in complaining of URIs. Again, things that irritate the airway. So those are probably the 3 most common, again, combining allergic rhinitis and postnasal drainage into one there, that you need to be aware of and have on top of mind. Other things that you need to be aware of. Any sort of inhaled allergen. So that can certainly be smoke, right? We're talking about not just if a patient is a smoker and if someone is asthmatic and they're smoking. Of course, we want to address that and try to get that stopped. But we're talking about exposure to secondhand smoke. There may not be a smoker themselves, but if we have exposure to secondhand smoke, fires, wood dust. Could be on the job, hobby, something like that. Also, other things that can be triggers for asthma, stress, emotions. Then we have medications. Beta blockers, which I talked about earlier, because it's blocking out beta. We're trying to stimulate beta because that helps to relax the airways and allow us to be able to move air. And then aspirin. Aspirin causes something, can cause, people have a sensitivity to it, something called Samter's triad. Come back to that in just a moment. Diet that is high in something called sulfites. Sulfites, most commonly found, beer, wine, hard liquor, alcoholic beverages, the stuff that you guys really want to consume right now while you're listening to this lecture. But basically, it's used in the food industry to prevent discoloration, and it is responsible for asthma in 5% of all patients with asthma. Well, I should probably say primarily focus on adult patients, because I don't think we have kids that are kicking back a fifth of Jack Daniels a day, although you'd be surprised as you get into adolescence. But anyway, so we have that. You also have other things that you need to consider, going back to talking about inhaled allergens or things that could be causing allergic rhinitis or postnasal drainage. Think about stuff in their home. What's the place that we spend the majority of our time at when we are home? And that's going to be in the bedroom, right? So you want to be asking about, are you having any down pillows or comforters? Those are made with goose feathers, right? Do we have pets? And if so, do the pets sleep with us in the bedroom at night? Keeping in mind that's where we spend the majority of our time, anywhere between 6 to 8 and 9 hours while you're sleeping. So if you have all that in your face, then that's going to be a problem, and that needs to be removed. And then the other thing that you can have is cold air. Not so much here in North Texas, where it's always about 105 degrees, but we still have our cold spells. As you have cold air that enters the airways in an asthmatic, it's difficult for the lungs to warm that air, and that can cause issues. So those are things that you kind of want to look at. Coming back over here to this aspirin for just a second, I mentioned something called Samter's Triad. This is actually something that I got on my board exam. And I've talked to several of the students from the previous cohort who have just taken or in the process of taking their boards, and a couple of them actually got a question about Samter's Triad on their boards. Again, this is having to deal with aspirin. So we'll talk about Samter's Triad. And that's going to be an aspirin sensitivity. It can also not just be limited to aspirin, but any NSAID. So ibuprofen, Motrin, Advil, Aleve, naproxen. You have asthma in there, we already talked about that, and nasal polyps. These are the three hallmarks of Samter's Triad. So what happens is patients who have a aspirin or NSAID sensitivity, they take it. It actually affects their airways because it inhibits something called cyclooxygenase. It inhibits oxygen, inhibits the flow of air. So as a result, it causes them to have asthma. And one thing that you can find in that history, if you ask them, do they take aspirin, do they take NSAIDs on a frequent basis, you want to ask them, have they ever had any issues, any sinus surgeries, or ever have had been told that they have nasal polyps. So this is responsible, kind of like with the sulfites, for 5% of asthma. Again, this is going to be in adults only. Why adults only? Why can't we have Samter's Triad in a kid? Well, because we don't give aspirin to kids, right? So these patients, by the way, respond very well to leukotriene modifiers. That's going to be your singular. So we'll talk more about that. But anyway, that's Samter's Triad. That's something to know. So speaking of kids, so what's different in terms of triggers and history, adults compared to kids. Well, a lot of this will certainly hold true for kids, with the exception of beta blockers and aspirin and the sulfites in the diet. Majority of kids under the age of 5 are going to have symptoms of asthma before they're diagnosed. Most common symptom of asthma is what? Cough and wheezing. So why don't we have a lot of kids that are ages 2 and 3 being diagnosed with asthma? Well, because in that age group, there's a lot of other stuff that can cause cough and wheezing, right? And it's found that we tend to do a poor job in the clinical setting in terms of asking about all these different triggers, and being able to narrow down that, hey, I think there may be underlying asthma going on. A lot of times we'll just write it off to allergies or whatnot. So with children, you kind of need to be aware of that. You'll hear a lot of different terms in kids used that are very similar to asthma, but not asthma per se, because again, nobody wants to tag a kid under the age of 5 with a diagnosis of asthma, because they can't beyond a shadow of a doubt rule out that there are other issues that are causing cough or wheezing. So you'll hear a lot of things about RAD, reactive airway disease. There's bronchiolitis. You're also going to hear stuff about asthmatic bronchitis, bronchial hyperactivity. So all that you'll see thrown around in kids. One thing that you do need to remember about the pediatric population, once they actually get established with a diagnosis of asthma, someone does their job correctly, that you need to know that 90% of kids with asthma are going to have something called, and hopefully you've heard of this before, what we call EIB, exercise-induced bronchospasm. So this is going to be exertional. In fact, that's one of the very common things you need to ask about with your triggers with kids, is symptoms with exertion. So those are the kids that you give 2 albuterol inhalers to, one for them to have at the house with instructions to use 20 or 30 minutes prior to engaging in any physical activity, and also one to be able to have at school to use before PE or sports or so on and so forth. So kind of keep that in mind with your kids. So as we kind of progress here, let's kind of get into the different classifications of asthma severity. So with our different classifications of asthma severity, we're going to have intermittent to start off with. Now, all of the classes of asthma severity are based off of components of severity, which is going to be symptoms, nighttime awakenings, use of short-acting beta-2 agonist, SABAs, your albuterol, interference with normal activity, lung functions, and exacerbations requiring the use of oral systemic glucocorticoids. So prednisone, prednisolone, so on and so forth. So with your intermittent, in terms of symptoms, should be less than 2 days a week. Nighttime awakenings should be less than 2 times a month. In terms of use of their short-acting beta-2 agonist, or having to use their SABA, having to use their albuterol, outside of prevention of exercise-induced bronchospasm, by the way, it should be less than or equal to 2 days a week, same as number 1. Interference with normal activity, none. It's not an issue. Lung functions, whether you're doing PFTs or using your handheld peak flow meter, which is better, by the way, it should be normal. You should have a ratio that is going to be normal, or it's going to be at or above that 0.80 or 80%. And then in terms of exacerbations requiring oral systemic steroids, that's going to be 0, maybe 1 time a year. So that's what we're going to have for intermittent. So then we get into a category of asthma that all falls under the category of being what's called persistent asthma. So within that, you're going to have mild, moderate, and severe. Mild persistent, moderate persistent, and severe. So using the same criteria that we did for intermittent, symptoms for mild persistent asthma is going to be over 2 days within a week, but not daily. Nighttime awakenings, 3 to 4 times a month. Use of their albuterol, it'll be more than 2 days a week, just like above, but no more than 1 time on a day. Interference with normal activity is going to be minor. Lung functions, again, just like with intermittent, it's probably going to be normal. And then requiring oral glucosteroid use 1 to 2 times a year. So, under moderate, symptoms will be occurring daily. Nighttime awakenings, it's going to be more than 1 time a week, but not nightly. So you can imagine what the use of short-acting beta agonist will be, since that falls hand in hand with symptoms, as we've seen so far in every stage. They're going to be using their albuterol on a daily basis. In terms of interference with normal activity, there's going to be moderate limitation. And now we start to kind of see lung functions change with peak flows or PFTs. We're going to see that ratio be above 60%, but now it's going to be less than 80. And they're going to be using oral steroids more than 2 times a year. And then for severe persistent asthma, symptoms are going to be all throughout the day. So not just daily, but through whole day. Nighttime awakenings, it's going to be just about every night, so 7 times a week. Albuterol use is going to be just like above, all throughout the day. In terms of limitation with function, of course, they're going to be extremely limited. do. Lung functions are going to be under that 60% mark. And they're going to have frequent use of oral steroids throughout the course of the year. These also, by the way, as we start looking at our steps here in a moment, come back up. Intermittent, that's going to be step 1, and then under your persistence, mild persistent. These are the hallmarks of step 2. They fall in that category. Your moderates, step 3, and your severes. I like when I go to the side of the screen, does it? That's going to be steps 4 to 5. So, then as we look at our stepwise approach to managing, this is where we start doing our interventions, pharmacologic, and always thinking about the other things that we talked about in terms of reducing triggers and reducing histamine. So, this is an up-to-date, these guidelines. These are, I believe, about a decade old now. These come from EPR3, I believe. Yeah, there we go, 2007. Due to be updated. There was talk that we're going to have new guidelines that were going to come out last year. That didn't happen. But anyway, this is still what we're going off of in terms of our treatment. So step 1, which we already talked about, are going to be our intermittent level patients. They're going to be on a SABA PRN, short-acting beta-2 agonist. Again, we want to relax that muscle. We want to get air in there. So that is albuterol, branded names, ProAir, HFA, Ventolin, Proventil, also includes levalbuterol. That's your Zopanex. Can be given in multiple forms. You'll most commonly see it in a metered-dose inhaler and in a nebulizer. It just makes sense in terms of there's that debate, what's better, a meter-dosed inhaler or a nebulizer? One works better than the other, onset's quicker. It's pretty much exactly the same. You got to keep in mind these patients are mobile for the most part. They could have an asthma attack at any time. Look at all those triggers that we talked about earlier. So ideally, it's kind of hard to tote a neb machine around with you. It's a lot easier to be able to carry a meter dose inhaler in your pocket. That's typically the way to go. That's typically the way that I go. Albuterol does come in a liquid and tablet form, by the way. And the onset of action for those is extremely slow. You only want to save that in people who, for whatever reason, can't do nebs or an inhaler. It's about a 20 to 30 minute onset of action. Also, sometimes there are some people who are just unable to use a SABA or use albuterol. I can think of one situation where beta agonists are contraindicated. That'd be if you have somebody on a MAOI inhibitor, in which case you are able to go to an alternative of an anticholinergic agent, which is also a bronchodilator, so something like ipratropium, which you know is one of the components of a duoneb. So anyway, so that's for our step 1 patients. So as we get into step 2, then those are our patients that we're going to have. They're going to be on their SABA PRN. That just carries over. Everybody's on a PRN SABA. they're going to have low-dose inhaled glucocorticoids. Okay, there are options for those that are intolerant that are listed below. There's the cromolyn, there's your leukotrienes. Theophylline. Theophylline's old school. That requires you got to monitor blood levels on theophylline. So anyway, we talked about that's going to affect our patients that now we're in the persistent stage. Those are our mild persistent. So if we have to get into step 3, now we're dealing with moderate persistent asthma. So those patients have their albuterol. They've been on a low-dose inhaled glucocorticoid plus a LABA, by the way. I forgot to mention that, a long-acting beta agonist. I'm sorry, as we get into step 3, they've been on their low-dose inhaled glucocorticoid and their SABA. Now we're adding a LABA, long-acting beta agonist. Or medium-dosed inhaled steroids. And then there's alternatives listed below. So you never have somebody with asthma on just a LABA alone. It's always with inhaled corticosteroids. Reason being, in asthma anyway, if they're just on a LABA alone, there's increased risk for death, particularly cardiovascular. That's why if you see the commercials for Symbicort and Advair, although Advair is not so much marketed anymore because it went generic, Symbicort's about to go generic, it always talks about this may cause death, particularly cardiovascular. So anyway, always keep that in mind. Important teaching point. You always have a LABA with inhaled corticosteroids. Never LABA as monotherapy with asthma anyway. And then as we're getting up into steps 4 and 5, what you see is pretty much everything stays the same. However, you're just upping your dose of your inhaled corticosteroids. You're going to medium and then to high in stage 5. Also, in step 5, it talks about omalizumab, which sounds like something out of Dante's Inferno. Anyway, it's a biologic. You want to stay away from that if at all possible. It's a monoclonal antibody. Some patients their asthma is that bad, they absolutely do need it. But number 1, it's expensive. Number 2, it has been shown to cause increased risk for cancer, especially lymphoma. So we try to stay away from that. Causing cancer in people is not something that we really try to set out to do, right? So one thing to keep in mind at each step here, you're always wanting to perform education. You're always wanting to manage and control surroundings / triggers. You're also wanting to manage other medical conditions, comorbidities, right? And that's over here in the side. So we're always checking that at every step. And then you assess control. Here's a nice thing about asthma. If they have been controlled at their particular step, the key here is for at least 3 months, then guess what? You can go down. There's no need to keep them at that step if we have them controlled. You can take them down. So, but again, the key there is 3 months that they have been controlled. And again, education, environmental control, and management of comorbidities at every issue. And also going back to the histamine cascade, that's got to be on board. Once you get to step 2, you want to consider sending those patients off to an allergist for allergy testing and possible allergy immunotherapy. That's where they have testing done, find exactly what they're allergic to. They get stuff mixed up specific to those levels. They get shots done on a weekly basis, starting off, and then it kind of gets spread out over time. So keep that in mind when treating asthma. You also need to make sure you have an asthma action plan in place with your patients. And that goes back to the education portion. So finally and lastly, when to refer. You'll see up here guidelines talk about consult with an asthma specialist, pulmonologist, if we're at step 4, or certainly we look like we're headed higher. So that's certainly reasonable, and that's certainly within the literature, and that's what you need to do. Other things to consider: if the patient has if they've ever experienced a life-threatening asthma exacerbation, otherwise known as status asthmaticus. Those of you with critical care ER experience might have seen this before. Then you need to make a referral. Patient has required hospitalization for asthma, or has had more than 2 bursts of oral systemic steroids in a year. Asthma that's not controlled after 3 to 6 months of active therapy and appropriate monitoring, doing all of these things. If a patient has been unresponsive to therapy. So those are all things to consider. The pediatric population. If you have a kid who's at least 5 and is at step 3, we talked about step 4 for adults, they need to be referred to a specialist. So step 3 in kids over the age of 5. So anyway, that's pretty much going to wrap things up in terms of asthma. I know we covered a lot of ground there in terms of definition, patho, diagnosis and triggers, different classifications, treatments, and the steps. And then when to refer. Hope this is helpful. There will be lectures to follow by me talking about all the different inhalers and medications that we talked about, the antimuscarinics, the steroids, SABAs, LABAs. I'm going to specifically break those down in a separate lecture because a lot of them are utilized and cross-utilized for both asthma and COPD. So I'm going to cover that all at once. And I'm also going to post a similar lecture like this that also kind of breaks down COPD and make things a little bit more simpler for you, I hope. So as always, any questions or comments, make sure you email me, text me, or call me. Be happy to go over any of this in a little bit more detail with you. But this is a good basic foundation and a lot of material out there to remember. But these are the main things that I really want you to focus on, and also some things that I've seen within my years of practice. And hopefully you kind of have an understanding now of why we give what we give and why we do what we do in terms of managing and treating asthma.